that you need to answer. Understand what I mean? Only deep, short information for the answer. If it will be like this, maybe like this, I think, like this, like this, like this, will be immediately additional questions. Understand what I mean? If you have straight question in examination card, please, straight answer. If I want to analyze or to know something from you about this question, I ask you with the additional questions. Understand it? Okay, perfect. Okay, yes, please. Clinical situation task. How looks? It will be the paper by 4 months. A4 is like this from both sides. Don't afraid that it will be big information, huge information, because if you at the examination part has more information, it doesn't mean that you have all information about these diseases. It will be easy to you to analyze what the real disease will be, yes, and what will be the final. Please read this, yes, quickly, please. Patient 27 years old turned to the dentist for the purpose of the oral sanitation. When collecting anamnesis, it was revealed that during the last year and a half, the patient had unpleasant sensation in the area of the lateral teeth of the upper jaw of the right. When pressing in the projection between the tips of 1.4, 1.5 teeth, and on the wing of the nose on the right, a moderately painful point is determined. If we never see this, and we know about only this information, okay, like this one, without any additional, what do you think? Patient suffering from something from the upper jaw, yeah? This is the time of diseases 1.5. It doesn't mean that this is not acute situation. And if the patient has now some problems about pain, about swelling, but we know from anamnesis that it was early first clinical situation 1.5 years ago, it doesn't mean that the diagnosis, that's right, will be exacerbation of chronic, not acute, please. First think, then talk. You remember some clinical cases from the first course. Remember how it was. First, you think, oh, now this, inflammation. But when we need to analyze what type of inflammatory process, we need to know the time of the diseases to analyze acute or exacerbation of acute. Then, if we read it again, the nose of the right is in the same size like the teeth, yes? 1.4, 1.5. If we analyze this clinical symptom, we understand that these two clinical symptoms has connection with each other. And if we analyze all information from last 3 years, from the third, fourth, and the fifth course, we know if something happened in upper jaw and it has closer relationships between the tooth and the jaw, what type of diseases it will be? If we check only this, we never see this, we think it's maybe exacerbation of chronic periodontitis, first of all, yes? Next one. Maxillary sinusitis, chronic maxillary sinusitis, in this case, exacerbation of chronic maxillary sinusitis. Then, what we thought about it, or it's maybe chronic osteomyelitis. Now we analyze that we have 3 different types of diseases. We need to find, I don't know what happened.
The other cup, this white one.
Where is here? Then we need to understand that we need to find something else to analyze what will be the real final diagnosis. We read another. About 6 months ago, after hyperthermia, swelling of the upper lip and soft tissue in the right suborbital area appeared. You remember acute maxillary odontogenic maxillary sinusitis. How perfect looks patient. Hyperemia, edema in suborbital area, pain under palpation. When we're chewing, patient can feel pain inside the jaw, bad smell from the causing area, causing site, and then were accompanied by increase in the body temperature and the pain in the anterior part of the upper jaw, more on the right. The temperature will be as the inflammation. Yes. Next one. You know that nasal and discharge, the patient independently applied antibiotics and the nasal drops as well as hot soda rinses after which a fistula opened of the gum and the inflammatory phenomena subside with a few days. It doesn't mean patients start to use 6 months ago antibacterial, antihistaminical and nasal drops by the course and had a right result. Stop the inflammation, but no therapy at that period. No. An objective examination revealed teeth 1.4, 1.5, 1.6, a charge in color, have mobility of the first degree. What does it mean when the ground changes the color? Periodontitis. Will you remember it? Then, have mobility of the first degree. You remember what the mechanism of changing this tooth stability? First, stability, not mobility. Please think, then talk. We need to have a good condition. You remember osteomyelitis, yes? When distraction of the bone surrounding the tooth or teeth and the tooth or teeth change the stability, lost the stability and has the mobility. Second one, anatomical features. You remember that the tooth from the upper jaw has closer relationships to the sinus. Yes. And you remember we have 3 types. I don't know what happened.
3 types of what?
And we have 3 types. Please, I continue without your help. Yes? And we have 3 types of relationships between the apex of the tooth, root, and the floor of the sinus. When the floor of the sinus deeper, maxillary sinus. That's the first reason. We have the big condition of the and good quality of the bone. What can happen that the tooth has changed the stability? The bone need to destroy it. Yes? And when the tooth lost the periodontal ligament in the apex around, change the stability and has the mobility. Mobility we have four stages. 0, no mobility. First, in one direction, vestibular or orally. Second one, vestibular and orally. And the third is vestibular, orally, and vertical mobility. It's first type. Second type, when the tooth has closure relationship with the sinus, but thick wall of the bone. Periodontitis the same, change the condition of the bone and change deeper inside. And the last third type, when the apex inside the sinus or covering only by Schneider's membrane or mucosa of the sinus. If we have pulpitis, we have good condition of the bone on this case. Yes? Why? It's anatomically. Pulpitis don't change the bone, but change the inflammation, starts the inflammation inside, because they has closure relationships from the apex with the Schneider's membrane. Here, if we have pulpitis, no changes of mobility, no, but has the same closure relationships and can stimulate the changes inside the sinus. Understand it? Then, if it will be there, pulpitis, no changes in the maxillary sinus. Read it again. How long present changes in the first and second premolar? How long? 6 months from the first symptom. What do you think? 6 months. It's typically for pulpitis or for periodontitis? Why? Chronic pulpitis, no. 6 months. Maybe 6 months ago was acute pulpitis, then changed to chronic. What's the difference between pulpitis and periodontitis?
Periodontitis obstruction of the bone, pulpitis no obstruction.
But the diagnosis percussion will be positive with periodontitis and pulpitis.
How looks the crown in pulpitis?
Colors change.
No change.
Color change.
Color doesn't change on pulpitis. In periodontitis, again, change in color. It doesn't mean that it's not the exacerbation of chronic pulpitis. It's the chronic acute or chronic periodontitis. When present mobility, we remember how roots has closure relationships, but we don't understand it now because we don't have the X-ray view. We need to check it on X-ray. Then patient go to X-ray examination. What we can find? These are the two different types of X-ray. One X-ray, one CT scan. Why we use the frontal part of X-ray. It's of course all extraoral. Understand it? If the doctors from the practitioner stomatological ask you about what type of X-ray you prefer, if you understand that present changes inside the sinus, please right answer.
Scan.
Understand why? We can find all structures what we interested, first of all, and the second, we can see all upper and the left, and we can use it for differential diagnosis to analyze the real etiology of these diseases. Okay, what we can find on this part? We see the changes of the color of the crown because the tooth was treated early with endo, first of all. And what you can find else? Maybe some doctors ask you about, I forgot. Do you have a pencil? If the doctors or me ask you where is you find the changes, how right answer? I analyzed the result of CT scan, or if it will be X-ray, you like a who answer you, because you like a doctor, not like your doctor, and how answer? I analyze X-ray, I analyze CT scan, I analyze MRI, and find changes from the normal structures, anatomical structures, around the first and the second premolars. Then ask what characteristic of changes. How right answer? Distraction of the bone around the two apex areas of 1.4, 1.5 with clear borders, rounded form, and the size about 8 to 1. 8 millimeters for 10, or 0.8 to 10, and to 1 point.
1 centimeter.
Yes, 1 centimeter, yes. You analyze. This is the right. Next. Describe the picture of the changes shown above. It's how you need to write answer for this. Then, make a diagnosis and make a treatment plan. How right answer? Now patient has inflammatory process. You agree with me?
Yes.
All agree?
Yes.
Yes. Now we know that this process stimuli has a odontogenic reason. We found two teeth. We analyze the knowledge from the last years. You remember, if some process stimulates the inflammation inside the bone, we need to use conservative surgical or surgical therapy. Make a diagnosis and make a treatment plan. You analyze understand what I mean? How is the right answer? I analyze the clinical symptom and the additional and I know from anamnesis, it doesn't mean you check all. Anamnesis, general condition, temperature, what you can see extraoral, what you can see intraoral, what you can find on additional investigations. And my diagnosis will be exacerbation of chronic odontogenic maxillary sinusitis, right side. Again, it will be full diagnosis. Understand what I mean? If you answer exacerbation of chronic maxillary sinusitis and you forgot the etiology, will be next question from examinator. What's the difference between odontogenic and rhinogenic? You need this question? No. It doesn't mean final. Example will be exacerbation of chronic odontogenic maxillary sinusitis. Then we have two, right and left. Right side. If you want to analyze more,
Number of things.
1.4, 1.5. Understand it? You closure your answer. If you write, use, diagnose it doesn't mean you analyze right. Clinical symptoms, anamnesis of diseases, now situation, and additional investigation. What will be the make a treatment plan? We know from odontogenic maxillary sinusitis we have three types: conservative and surgical. But on this case, we understand that it's impossible because we have distraction inside the maxillary sinus. It doesn't mean that the inflammatory process goes deeper to the area of the maxillary sinus. Conservative and surgical, what does it mean? It means that we can open the tooth using the secondary endodontical therapy, and then wait to analyze about the surgical procedure for chronic treatment of chronic periodontitis. It's impossible to use because the zone deeper in the sinus. Unfortunately, we can use only surgical. We can use how to answer. If it will be this process in the bone, not in the sinus.
Kills my brain.
If it will be the situation, no changes inside the sinus, we can use conservative and surgical. Understand it? Now it's impossible. Unfortunately, we need to use surgical therapy. How we use the surgical therapy? Patient now has edema, again, has the degree of mobility. Understand why present mobility of the tooth. Because the bone around destroyed. Understand it? Then mucous membrane moderately edematous, high cyanotic tender of the level of the middle of the root of the fistula with scanty serous discharge. We have fistula formation. It doesn't mean that the all situation from this area go into oral cavity. Imagine you, like a doctor, extraction the two teeth. What happened? Fistula formation present.
The food go from the tunnel.
Mm-mm. We need to understand this is the bone or some parts of the bone sub of the mucosa, because you know how inflammation growing. It can grow with distraction of the bone, and going deeper change the level of distraction. If you remove these two teeth, maybe perforation with the sinus. And what happened?
The food will move to the nose.
We need to change the situation. You have, after extraction, acute perforating maxillary sinusitis. Understand it? Yes. If after extraction we have a purulent exudation, possible to closure with the mucosa disconnection? No. First of all, you have the fistula. This is the
Point of view.
defect of the mucosa. And you need to use the vestibulary part for trapezial. You remember when we discussed the maxillary sinusitis, how closure, the connection with the maxillary sinus. We need to use the plastic procedure. 4, 5, 6, 7. You want to remove this too because we have exacerbation of odontogenic maxillary sinusitis. You removed it, and then after removing, we have the perforation and acute perforative maxillary sinusitis. What you should do? You need to use the trapezial flap from vestibulary, and you separate its full thickness flap. It does it mean with periosteum, mucoperiosteal flap. You separate it, open, then you need to use inside the locally penetration. For you need to cut inside the periosteum, because the periosteum doesn't has a stretcherous fibers, only mucosa has elasticity. Then you perforate inside the periosteum and change this vestibular part to the palatal and closure it. Understand? Then we can use this uterus, non-resorbable, and use the anti-inflammatory therapy. Anti-inflammatory therapy consists of antibacterial, antihistaminical, painkillers, then local anti-inflammatory therapy with antiseptic irrigation and application with special parts. For example, levomicol or Metrogel gel.
Special what?
Metrogel gel or levomicol. We can use the special past for application. If we can use this, it's the right therapy. What will be? You have after extraction purulent exudation. You are a brilliant surgeon. Okay, it's no problem for me. You use the flap design, closure it, but pass now, not under the control. And the pus secretion will be continued. And the pus going between the sutures in the empty socket to the oral cavity, and what happened with the tissures with under the pyrolytic sedation. Patient come back to you to the next day, maybe after 1, maybe after 2, with open wound. What will be next step if it happened? We need to go with the patient to maxillary surgery department. And maxillary surgeon see your eyes because it was wrong technique. What we should do?
Which technique?
About flap in the pyrolytic sedation. What we should do? We need to start with this, and when the condition of the patient, usually after 2 or 3 or 4 days, when you start antibacterial, antihistamine, painkillers, and nasal drops, you can use this technique. Understand? We don't use now surgery, then anti-inflammatory. We start with anti-inflammatory to produce the answer, the organism answer, like an antibacterial effect here to kill the microbes there and stimulate the new mechanism of regeneration. And in this time, you can use this surgery. What will be the right answer about? We need to use surgical procedure, but before we need to use anti-inflammatory therapy. We wait 2-3 days, then we use surgery with extraction of these 2 teeth and flap design. Easy? Very. Then, when you can use, guys, please, we need to continue. What will be the right answer? Why I discussed with you like this? Because we have the next question. Name possible intra and post-operative complications. First of all, it's not the complication from your works. We have the connection with the sinus. It happened because it's anatomy. It doesn't mean that possible intra-operation is the acute perforating maxillary sinusitis, first of all. Next, post-operative. Open the necrosis and maybe abscess and phlegmons. Again, you analyze the clinical situation and additional x-ray on this case. And my diagnosis will be exacerbation of chronic odontogenic maxillary sinusitis right side near 1.4, 1.6. Then, what will be the treatment plan? For this situation, we can use only surgical therapy. And the surgical therapy consists of 2 steps. First, general anti-inflammatory therapy. Then we wait 3 to 4 days and remove 2 teeth and use the flap design to closure. Not immediately. We wait. first, we prescribe the antibacterial therapy, wait 2 or 3 days when the general condition will be better, the nose breathing will be better, and then we remove 2 teeth in the same time using the flap design. Because after tooth extraction will be connection with the sinus. Then justify the choice of incision in this clinical case. Trapezial vestibular flap. Some doctors from practitioner, I don't know what happened, use the other part of the flap. When we can use the part from the palate. The same, we remove 2 teeth and using the lingual palatal flap. But the lingual palatal flap, how to analyze what will be the size? If we discuss the vestibular, it's easy to use. You can use one medial part and one distal. With the, when you have the connection with canine and the molar. On the palate, it's impossible to use the same size of the flap because on the palate, no submucosa layers and the thickness of the mucosa bigger, but the quantity it's harder. It's impossible to rotate like you can rotate from the vestibular. And how to analyze this? When you cut here and rotate, it will be rotate only 30%. You need to analyze how many you need in millimeters, and from the middle use the same size. Understand? Because when you cut this, you need to rotate here this palatal flap. The same. You need to use the same. What will be the trauma on the palate? Huge. And when you rotate it, you have a bone without covering, without nothing. It's the open for all microbes and for the tongue. Patient cannot real normal live with this situation. How to answer? Possible to use, but we need to analyze how many teachers we need. And if you analyze, you remember it's canine and 2 incisors. The area of the operation will be between the central incisors. And the time of regeneration will be like this. We need to use the easy technique with easy surgical procedure with short post-operative period. If it's impossible in some cases use vestibular, we can use palatal. But now you understand the positive and the negative. Don't analyze immediate, when you answer. If you have additional question about, have you any technique, do you know any technique about the closure? You answer, yes or no. We can use the flap from the palate, lingual. This is trapezial, the name, vestibular. and the lingual from the tongue. Lingual because it looks like the tongue. Why the name of lingual? Not we can take the part from the tongue, but it's lingual position, and that we can use this one. It will be how you choose. If it will be next question, how you choose between this or between this, you answer. We know about the positive and the negative. If impossible to use vestibulary, we can use lingual. If impossible to use vestibular and lingual, we can use same technique together, vestibular and the lingual. It's the very hard technique, lingual and vestibular and bilingual. That's why we prefer use vestibular, because the time of rehabilitation will be shorter. The effect of eating, talking, no changes, and the time of regeneration about 10 to 12 days. On the palate, about 3 weeks. Cannot eat, cannot talk. Yes.
In which case we can use vestibular?
On this case,
Generally, in which
it
case?
depends on the situation. Sometimes I don't use the vestibular and lingual. I take the graft from the tuber, full sick, and separate vestibulary, and create like a pocket, fix inside and closure. But you need to use the yes, or you need to use the binoculars because you need to see it, how you can closure inside and suture inside. Because when you use the graft from the tuber, very important to analyze where is the bone. Because sometimes you see the huge tuber, but the thickness, how you analyze? You can use the probe and to analyze where is the bone. If bone here and the thick part of the mucosa, you can take like triangle inside. You take away these two pieces, sutures together, no post-operative area, and this triangle put you fix inside vestibulary, but you create like a box from vestibulary part. It's absolutely different technique. For your right answer on this case, you need to use the classical type. Classic is the trapezial flap from vestibula. Who talk? Yes.
Doctor, in this case, we have the mobility for three tooth, but
Yes.
the mobility from the second type is for one tooth. We have fistula. We can use the gutta percha to understand which tooth is the causative tooth.
Yes.
We can extract one tooth, not two.
It depends on the situation, because if you have the mobility, you need to analyze the real structure and the length of the root. On this case, for your right answer, you need to remove two teeth, 1.4, 1.5. In real life, you need to remove 1.4, 1.5, 1.6. Here, because the bone, destruction of the bone about 2, real life and your right answer, unfortunately, different, because you need to finish the medical university. Now we're training for the right answer. For real life, no. We remove 3 using the same procedure, bone graft technique, using the procedure with flap from the tuber to create the attached gingiva immediately. Then we wait 4.5 months, and then we took 2 implants here without any bone graft procedure inside the sinus. Because you put inside on this cavity with the special technique, you break with those plastic materials, and you, from this is the bone. This is the level of the bone. This is the empty, yes. And when you put inside the membrane, then you put inside the osteoplastic materials, you immediately create the full thickness of the bone. And you can use it for 2 implants and finished. Next one. Patient, 21 years old, went to the dentist, complained of discomfort in the lower jaw area of the left, pain radiating into the ear and temporal region. If we don't see the picture, what do we think about? I don't know. Pains, discomfort in the lower jaw area of the left, irradiating into the ear and temporal region. Remember when we discussed neurology? Yes. First of all, I think like this one, because no any clinical picture about change the configuration, no eating, pain at the eating. Then, from anamnesis, 6 months ago, painful swelling on the gums in the area of teething tooth, 3.8, periodically occurred, with the accompanied by the pain when swallowing and difficulty opening the mouth. Now we know that this situation maybe has connection or closer relationship with the changes inside the oral cavity. The patient independently applied analgesics, carried out local anti-inflammatory treatment in the form of soda rinses and application with levomicol ointment, did not seek medical help. At the time of treatment, the following clinical picture was revealed in the oral cavity. What we can find in oral cavity? Of course, we can find the patient with upper and the lower jaw with the teeth. Yes? We need to analyze the quadrant number 3. This is the lower jaw, left side. What you can find inside? Of course, you start with right. We don't analyze this one. Because in some cases, therapeutical and prosthodontical, you have not only question about the causing area, but about all. And you need to analyze all. Now we can see only this quadrant. Then we check on X-ray and take the more information from this. What we can find? We can find the crown normal 6, yes, first molar, second molar, and we can find the part of the crown of the said molar. We remember when the tooth growing, how this how this condition named. If tooth doesn't grow for full, but stimulates the inflammation in the mucous membrane around the crown. Pericoronitis. How many parts of pericoronitis by classification we know? Acute and chronic. Acute, how many? Serous and pleural. Here, how it looks? Acute or chronic? 6 months. Exacerbation of chronic pericoronitis. Different diagnosis. Different. Please first think, then talk. When you talk, will be the machine going with new additional question to you especially, because it was your anamnesis or your diagnosis. Okay. What will be checked? What we need to check on the patient? Crazy. Crazy situation. We need to analyze what real inside. Yes? Of course, it looks like the part of the crown. No trauma, no nothing. But we need to analyze what is it. After examining of the patient, radiography was prescribed by the doctor. Make a diagnosis and describe the characteristic clinical picture of this disease. How you need to answer. After clinical situation and X-ray. After analyze this, I think that diagnosis will be
Secretion, dermatitis,
Odontogenic.
of chronic pericarditis 3.8.
8.
No need to answer which side. Pericarditis, it doesn't mean it's the mucosa around the tooth. Pericarditis may be at the child when the first molar growing the same. We need to analyze around the number of the tooth. Again, exacerbation of chronic pericarditis 3.8. Stop. Describe the characteristic clinical picture of this disease. Describe. What does it mean, describe? You found why it's pericarditis. Understand it? Why exacerbation? First answer. It was first symptom 6 months ago. Now patient going to the dentist with the symptoms of the pain. And pain is a symptom of inflammatory process. It doesn't mean that this exacerbation of chronic, this is the phase of diseases. Then what you can find inside oral cavity for pericarditis? Some part of the crown covering by mucosa. What you can find on X-ray? Describe the OPG X-ray. Describe. It doesn't mean it will be full answer from 4 quadrants. Caries, filling. Said molar.
Is your undulation?
What we forgot, how to answer. First, you need to analyze the caries. Then you need to analyze pulpitis and periodontitis. Then you need to analyze, was endotherapy or no? Was endotherapy? No. Only the filling here, yes? And here. What is it? It's the milk teeth. What will be the final diagnosis for OPG from the OPG? Which teeth? No. If milk teeth present, which teeth absent? Check. 1, 2, 3, 4, 5. No. Because the first molar is the same space like second premolar. You remember how many teeth in milk?
Yes.
No, third molar, no second premolar. All the same, 20, yes? And no second molar. We don't have second premolar, second molar, and the third molar. What about the third molar from the lower jaw? Then we need to discuss the position. It's the same position like the third molar. No. The third molar has horizontal position. No space for normal growing. Understand? Why no space? Connection and the position. Because the second molar, it's like the part for the growing row. And the horizontal position has no normal relationships with adjacent teeth. Describe OPG. Not describe only this. Describe all OPG. Additional question. What is it? This? This?
Pulmonary sinus.
Maxillary sinus.
No.
Not upper. Maxillary sinus here. This is the nasal cavity. Not you mean. This is the nasal cavity. This is the maxillary sinus. What is it? What is it? Vertebra. Welcome. It's not the line of the fracture. When the patient say at the OPG, this going around here, and the first and the second vertebra has the same level, like the angle of the mandible and the tuber of the maxillary. It doesn't mean has. We have the picture of the first and the second vertebra. What is it? Condylar process. Not TMG, condylar process. The same. And glenoid fossa. What is it? Inferior alveolar nerve canal. Perfect. Analyze. We cannot find any changes in maxillary sinus. No changes. No changes. We cannot find any foreign bodies inside the bone. No, it's clear. The structure, like it will be normally, looks like physiological, has the same physiological picture. And what is it? Who knows? No. Which bone has connection with the muscles of the floor of the mouth? Make a treatment plan, guys. Make a treatment plan and list possible complications. The treatment plan consists of two big groups. First, we need to analyze what we should do with the said molar at first. And the second one, we need to analyze what we should do with the milk teeth. Is the treatment plan, surgical treatment plan. Why we need to discuss with the patient about extraction, the milk teeth. Patient 21 years old. We cannot wait any time because no, it's only milk teeth. But if the milk teeth present more in oral cavity, you know that the milk teeth has mobility more than the physiological mobility. I mean that the physiological mobility of the permanent teeth. What can happen? These two teeth change the position, and the milk teeth position change inside more lingually, and will be traumatized or the tongue. You know what about the chronic mechanical trauma? Stimuli the transformation of epithelium, and then, first of all, and second, oncology start. Why we need to analyze? Your treatment plan will check all problems. And we need to analyze, of course, patient come back to you with the inflammatory process around said molar, because the patient has inflammation, clinical inflammation. Patient don't understand that this is the milk teeth, really. When we check it on X-ray and analyze, and when we discuss about how you're growing, and the mother, this patient asked the mother about the milk teeth. She said that it was more than 20 years. I don't remember about this, how it was. We need to analyze all. First symptom, we need to change the inflammation to stop the inflammation. What will be discussed? How and in which time we need to remove the said molar. Do you remember the indications for tooth extraction? What will be the first indication? General indication. It will be the indication. We have two types of indications, immediate and delayed. What about the immediate indication?
Third, the mobility of
Said mobility of the tooth. No. Second, crown destroyed than more 50%. No. Next. Root fracture or vertical fracture of the tooth. Next. When tooth has closure relationships with inflammation and stimuli this inflammation. For example, acute odontogenic osteomyelitis. It doesn't matter was treated endodontically. It doesn't matter saved or damaged crown. It doesn't matter the position. We need to remove it immediately. We have inflammatory process. Yes. And how to treat the inflammation? We need to take away the etiology and prescribe the right therapy for stop the clinical symptom of inflammation. Here, position of the tooth depends with inflammation, because if the tooth has right position, what we should do? Вообще, я буду как крокодил злая. If the tooth has the position like this one, like vertical position, what we should do? We only need to cut the surround mucosa to open the crown. If you cut here, you can find all crown.
No,
Why?
because
The position horizontal. If you cut the mucosa, finish the inflammation. No, because tooth has horizontal position. What will be your treatment plan like a doctor? First, we need to remove the wisdom tooth. Why we don't use the aperectomy? Why? We don't need to cut the mucosa. Because your surgical procedure not help the patient, but stimulates more inflammation. Because inflammation has closer relationship with the horizontal position. What we should do? We need to extract the tooth, because the treatment of exacerbation of chronic pericoronitis and disappear of the said molar will be extraction of the tooth. Not cutting the mucosa, only extraction. But extraction we should use with anti-inflammatory therapy. Please, when you answer, we have standard protocol of anti-inflammatory therapy. It doesn't matter what we treat. Salivary glands, tuberculosis, osteomyelitis. Anti-inflammatory therapy consists of antibacterial, antihistaminical, desintoxication, painkillers, and local anti-inflammatory therapy consists of antiseptic irrigation and application with the special ointments or pus. It depends on the period of inflammation. First 3 to 4 days we prescribe with antibiotics, then with the past who has stimulation of microcirculation here. Знаю, что с ним сделать уже. Okay, list of possible, it was first step of the therapy. Second step of the therapy, extraction of the milk teeth. Guys, please, extraction of the milk teeth and the dental implantation. If you answer only extraction of the said molar with anti-inflammatory therapy, it will be not full answer. Will be additional question, full answer for this patient, because you have analysis of OPG X-ray. The treatment plan consists of two big parts. First, extraction of the said molar with anti-inflammatory therapy. After, when it's regenerate, maybe after 1 month or bigger, what the patient prefer, we need to remove the 2 milk teeth and fix the implant. If the maybe something else ask you about why you prefer the dental implant on this case, you answer how. No permanent teeth, it's a milk teeth, no function. Milk teeth changes the configuration of the normal adjacent teeth. Why you cannot use the classic type of prosthodontical therapy with the bridge? How right answer? No caries, no pulpitis, and the patient age is 21.
We cannot remove the milk teeth and close the space with the orthodontic treatment.
No, it's impossible. Because the first molar has contact with the 2 premolars. It's a mistake for the bite. The patient, if you use this technique, after 3 years, will be clicking of TMG, because it's absolutely different function of the premolars and molars. And connection between between these two different, because the molar has on the lower jaw more lingual, premolar has more lingual position like molar, and when you change the molar to the side of premolar, it will be you change the normal configuration of the bite, of the occlusional part of the bite. It's impossible to use. Possible complication.
Doctor, please, if the wisdom tooth will touch the inferior alveolar canal,
We need to remove it at the maxillofacial surgery department. We have indications, immediate and delayed. It depends on the condition of the patient, on the systemic diseases, and the technical procedures. If you cannot use this technique at the polyclinic, please go to the maxillofacial surgery department, because they can use immediately the special therapy for take away the edema around the nerve. It's impossible to use at home because it's the intravenous injection. Possible complication. Possible complication for 2 parts, for third molar extraction and for the implantation. For maxillary, for extraction of the tooth, any complications like the complications in the period of extraction and the period after extraction, but if you don't use the technique of tooth extraction, you want to take away the pieces of the mucosa here to create the space like you think. What will be? Abscess or inflammation will be deeper and symbolize the purulent exudation with, you remember how, when we discuss abscess and phlegmon, how purulent exudation transform the spaces. Where is the space? What's the name of the space has closure relationships with the wisdom teeth area? Pteryga mandibula, retromandibula, and pteryga mandibula. You remember the abscess and phlegmonas, these two. This is the complication. Of course, the bleeding will be, but on the operation part, we have the bleeding, it's no problem. It's the result of our therapy, but about the post-operative will be bleeding. Maybe will be bleeding. Describe the method of surgical intervention on this situation. How remove this perfect horizontal third molar? View from occlusion. Guys, view from occlusion. This is occlusion of the second, this is occlusion of the third, of the first. This is the part of the crown, this covering by mucosa. Where will be the flap design? In the center of the alveolar process. Here, because this is the open part, understand? If it will be all closure by mucosa, the flap design will be to this, but some parts covering covering and open you can see on the crown. Then you use this and this. How it looks? Trapezoid. If for you imagine enough the space only cut here without, how will be the name? What will be the name of the flap? Angle. Angle. We don't have triangle, we have angle. Angle or trapezoid. If here no space, we can change it here. It will be angle or trapezoid, but the peak will be in the center of the second molar or between first and the second molar. It depends on the space. It not depends on your choices. It depends on the real length, width of the patient. Then, look, how to answer? Local anesthesia. Flap design. Next. Separation of the crown. Which instrument you can use for separation of the crown?
Surgical pair.
Surgical bore with cooling. Then next step, separation of the crown. Next, extraction by instrument. Of course, if I hear the forceps, will continue again in the next year. Not together, all together, continue. Extraction by the instrument, straight or angled elevators. Then you extract only the piece of the crown. Then you use again separation of the roots and extraction one by one. Then antiseptic, irrigation, then flap to the right position and suture. And this is the step of the treatment. No. Anti-inflammatory treatment. Antibacterial, antihistaminic, painkillers, local anti-inflammatory therapy. Local anti-inflammatory therapy, antiseptic irrigation, and the special ointment with with antibiotics or with the Metrogyl gel. Easy. But you need to think before when you answer. Because if the words going from your mouth, it's like the birds. But maybe birds like beautiful, and maybe birds with the big deals from these birds. Understand what I mean? Next. Patient this 10 minutes break and come back for 2 because I need to finish at 1. Patient 53 years old, complained of difficult eating and talking due to the severe pain when moving her tongue. What we know? Patient cannot eat because patient feel pain when the patient chewing. Then, the presence of swelling in the right submandibular region. An increase in the body temperature 37-38. Sleep and appetite disorders. If it's submandibular region, it may be diseases, lymphadenitis, abscess and phlegmons, periosteitis, osteomyelitis, and we forgot about the diseases of the salivary gland and sialodenitis. It may be non-specific and specific. Next, from anamnesis, it was revealed that during the last few months, the patient periodically experienced birthing pain and swelling during meals in the right submandibular region. Patient know that the patient suffering from this disease in the time of eating from one side. It doesn't mean it's not systemic diseases. Then, these symptoms were eliminated independently with 30-40 minutes. We remember my favorite diseases of the salivary gland.
Cellulitis.
We have acute and chronic. Acute may be bacterial and viral. Chronic may be, acute may be the name of cellulitis.
Chronic. Ductal.
Parenchymal and interstitial and
Ductal interstitial
stone formation.
Cellulitis.
It's not typically, it's not systemic diseases, but we have systemic diseases. The Sjögren syndrome and Mikulicz syndrome, and we have it's viral, yes. We discussed about the bacterial. Cellulitis is the stone formation, yes. We have chronic and exacerbation of all this. Perfect. New information. These symptoms, did not the patient much, so she did not go to the doctor. How many days last few months? If it's last few months, it doesn't mean that it's not acute. This, you remember how progressive the diseases of the salivary gland. They need more time. Вообще прекрасно. Что тут происходит? Okay, if it's few months, it doesn't mean, and you remember, before first clinical symptom, patient lost 3 to 4 years. You remember this information?
when start some interstitial or parenchymal sialadenitis before when these diseases start and the first clinical symptom 3 to 5 years. If the patient suffering lasts some few months, this doesn't mean that first symptom present some months. If you analyze, thus it's not the acute process, it's exacerbation of chronic sialadenitis. Then 3 days ago the pain increased dramatically, became permanent, and there were diffuse swallowing, talking and chewing food. Due to the increase in symptoms, the patient had to go to the dentist. Objective examination changed the configuration of the face due to swelling in the right submandibular region. Really looks like abscess of ligmoid. Yes? Enlarged, painful, mobile regional lymph nodes are detected by palpation. Or acute lymphadenitis. If we understand how many days, it does mean purulent lymphadenitis. On the red border of the lower lip, there is a rounded, soft, blush-colored formation protruding above the surface, painless, paling when proceed. Open the mouth is not difficult. The right submandibular salivary gland is enlarged, compact, and painful. In the right submandibular area, a sharply painful, inflammatory infiltrate is palpated. The mucous membrane about it is sharply hyperemic. More clinical symptom for abscess.
No.
It's right sublingual area.
Right sublingual area, yes. Then, the duct of the submandibular salivary gland is palpated in the form of a dense, painful string. From the mouth of the duct, there is an purulent exudate. A general blood test revealed moderate leukocytosis and increase and rate. Make a preliminary diagnosis. Please, how to write answer? After analyze the clinical symptom and this beautiful what you can find and here more symptoms for exacerbation of chronic sialadenitis. Make a plan for additional examination necessary to make a final diagnosis. I can ask you why you think that it's the sialadenitis, non-abscess of ligmoids. How to X-ray before after, X-ray after. How you analyze? If it will be abscess of ligmoid, you need to feel fluctuation. No symptoms for fluctuation. Purulent exudation present, but from the duct. It doesn't mean only they change the condition of the salivary gland. Make a plan for additional examination necessary to make a final diagnosis. What's the name of this?
What?
Maha, I kill you before exam. Sorry. What is it? What's the name of this additional investigation? X-ray of the floor of the mouth. Sialography is the method when you can take the quality and quantity of the saliva from the salivary gland. Please. is the methods when we can use to analyze the stage of interstitial or parenchymal sialadenitis. Here, this is the X-ray of the floor of the mouse. If you want to analyze what happened really with the structure, we can use X-ray with contrast. If the patient has purulent exudation, we never use this technique because salivary gland is like a ball, has capsula. Purulent exudation changed the size. Capsula not stretches. And you, like a perfect doctor, inject inside more liquid. What happens? And we can lost the salivary gland. Then, how to remove the salivary gland submandibular? 4 hours of operation under microscopic. Without microscopic, patient will be absolutely with the problem by cosmetic, and the problem was the function. Differential diagnosis. To make a final diagnosis, we know that this is the X-ray of the floor of the mouth. It's intraoral or extraoral X-ray. Here put the film, it's extraoral. Of course, in the paper, you can find the small pieces with high contrast. It doesn't mean that this is the small pieces, this is the stone. Sialolithiasis, absolutely. It will be final diagnosis. Make a differential diagnosis. What does it mean, make a differential diagnosis? Please. No need to discuss all diseases. Only this area, lymphadenitis, periostitis, osteomyelitis, abscess and phlegmons, and specific.
And what is the difference?
Please only answer between which no need to differential diagnosis. When you start to differential diagnosis with positive, negative, or the exam will finish after 1 month. We need only to analyze that you understood between which diseases you need to be differential diagnosis. Don't use full differential diagnostics, only by the name of diseases. Then, make a treatment plan. Generally, for this patient, understood in which department we need to treat this patient. In which department? In maxillofacial surgery department or surgical department. Because it's not the polyclinic area. We don't know really how many days. Patient has diabetes, hypertension, 53 years. Yes. Кому там надо домой? Все пойдут сейчас домой. And first of all, hospitalization is the treatment plan. If you prescribe right therapy, of course we prescribe anti-inflammatory therapy, general and anti-inflammatory therapy local. We don't know about the stage. Maybe patient will go to the maxillofacial department at this time, capsula of the salivary glands and the all purulent exudation after 3 to 5 hours will be immediately in the muscles. Of course, we need to treat this patient under the control to analyze. Maybe we need to use surgery immediately, we don't know. 2, prophylaxis of complications, and to the right treatment plan, we need to treat this patient at maxillofacial surgery department with general anti-inflammatory and local anti-inflammatory therapy. Understand? If some doctors, maybe me, ask you for how many days we need to prescribe anti-inflammatory therapy, how right to answer? We need to prescribe for 10 or more. It depends on the result of answer, the body of the patient, of the reaction of the patient. Yes. If ask another question, what we should do with the stone? Possible to remove the stone from some mandibular gland?
No, extraction of all the.
Gland.
It depends
Depends
on
on the
the
size.
position of the stone. On this, we don't understand where is it. We only find where is it. We need to use MRI or CT scan MRI to analyze where is real this stone has position. If this stone, you remember that submandibular and sublingual glands has one general duct. Maybe if the stone localized on this duct, we can use the surgery for extraction this stone. If it has deeper position, it's impossible. If we need to remove this, impossible without removing the whole body of the salivary gland. Understand how to answer? Perfect. What's the most dangerous complication? Inflammatory complication, formation of abscess and phlegmons. Then, during surgical treatment, it doesn't, yes, bleeding or trauma of the nerve, or during the surgical treatment, or wrong technique will be with bleeding and there was damage of the nerve, unfortunately. What else? It's not the complication, but the operative access will be extra orally. It doesn't mean that the after we need to use the plastic surgery. It's the not dangerous complication, but it stimulates the scar formation. And secondary after this procedure, we need to use the plastic technique. Break for 10 minutes, then come back for 2 cases and finished. I start.
خلينا نخلص بس يا جدعان.
Patient 50 years old went to the dentist complaining of swelling in the submandibular region of the left for a long time, the appearance of a fistula. Anamnesis 4 months ago, patient received treatment for chronic sluggish pneumonia. After a while, painful swelling appeared in the submandibular area, moderate pain when swallowing. The dentist diagnosed lymphadenitis of the submandibular region of the right, prescribed antibiotics, which the patient took for a week. However, the condition practically did not change. The swelling remained, gradually become denser. A softening center appeared in the center. There is a periodic increase in the body temperature. In the afternoon, general weakness, decreased appetite and body weight. Objectively, the condition is satisfactory. The body temperature is 37.3. In the submandibular areas and in the neck, enlarged, slightly painful lymph nodes are palpated, sorted into package, having a tightly elastic, almost cartilaginous consistency and clear contours ranges in the center from 1 to 3 centimeters. Limited mobility, moderately painful. It's odontogenic lymphadenitis. Odontogenic lymphadenitis. No any clinical symptom for odontogenic. No any complaints for the tooth, from the teeth. Nothing. Only has changed the general situation about the pneumonia. Pneumonia was treatment. Then starts to change these lymph nodes. With these lymph nodes, patient go to the dentist. Dentist prescribed the normal antibacterial therapy, no result. What the patient has? Patient has fistula formation, round form. This fistula formation, the same contours like the lymph nodes. It has the cartilage elasticity with this exudation. Know any about purulent exudation with white, scanty purulent discharge in with individual card inclusion can be traced. Mouth opening is free, the oral cavity needs to be sanitized. What do you think? It looks like acute or exacerbation of chronic granulating periodontitis. Remember when they start the distraction of the bone and stimulate the fistula formation. It's only typically for granulated periodontitis, yes? Or fistula formation typically for osteomyelitis. Maybe this looks like the osteomyelitis. Patient needs to be sanitized. It doesn't mean that present some teeth for treatment, maybe for extraction, but no acute process in oral cavity. No any clinical symptoms about the teeth mobility, about the edema from the alveolar process from the both sides of alveolar process from both sides. If not any, it not be like the osteomyelitis or acute, subacute or chronic. If you remember, we have two types of inflammation, specific and non-specific. Non-specific is a typical inflammatory process who has closure relationships with the microflora in oral cavity and the microflora from the pulp, from the root canals, and from the salivary. Specific, it doesn't mean that the some neutrophils or macrophages kills it immediately and non-stimulates. Because non-odontogenic, non-specific microflora is 85–95%, and 5% is a specific. What's the name of specific microflora, do you know? Diseases. Actinomycosis, syphilis, tuberculosis, and this, what about the skin? With the right, erysipelas. Guys, what do you think? If we remember the forms of tuberculosis, how many forms of tuberculosis from classification we know? It's not the tuberculosis type. It's actinomycosis and it's 10. Tuberculosis will be Miller ulcers and scrophuladerma. Remember it. Tuberculosis maybe has period. Remember it, period of tuberculosis. What will be the period before microorganism going to the body, transfuse and come back, or transformation and come back to the same space? For tuberculosis, how many we need? How many times? How long this period? Incubation period for tuberculosis.
4 to 6 weeks.
2, 3 days.
4, 6.
From where you remember?
3, 4 weeks. 3, 4.
1 month.
1 month, 3, 4 weeks.
21, 28 days. 1 month. Maybe 3 months. It depends on the immunity. If you remember the syphilis, what will be the incubation period for syphilis?
2-3 weeks. 2-3 weeks.
Specific don't have days, they need more. It not depends the name. All specific need more because they need first fight with non-specific bacteria, then transformation. Microbiology, forgot for all. No. Syphilis, how many?
2-3 weeks.
2 weeks. 2 weeks.
From 2 to 3 weeks.
We have period of syphilis, secondary,
Sec-
primarily, third period, fourth.
Mhm.
4 weeks.
4 weeks.
We have seronegative period and seropositive period. Actinomycosis,
4-6.
incubation period, how long?
4-6.
1 month.
4-6.
Syphilis has only one type of clinical situation. I mean, one form element.
Primary is ulcer.
Depends on the period, yes. Actinomycosis,
10 classification. 10 we have.
forms, yes. What do you think? What the etiology of tuberculosis?
Tuberculosis. Treponema. لا الألسر.
Mycobacteria of tuberculosis going from the body, going to the vessels, to the blood, and localize inside the lungs. Then transform 28 days and come back
To the area
to the
was
first
inserted.
investigation place. Okay. Actinomycosis. Where found the tuberculosis? Mycobacteria of tuberculosis. Where the patient can find this? From the ill patient with tuberculosis, with the transfusion, and when we can use the instrument without disinfection and sterilize. Actinomycosis live inside the body or live on the skin. Live. It's there. What's the name of this microorganism? No, the types.
Two aerobic and anaerobic.
What is the type of this microorganism? It's typically for the skin, not typically for the skin.
Typical.
Maybe this microorganism has the typical place for living inside the oral cavity.
And they make upset.
Non-spore.
Hmm?
Non-spore negative.
Non-spore negative, but this microflora typically, physiologically for the body, with small concentration, or no?
Yes.
Yes. Tuberculosis not typical. Actinomycosis typical. Syphilis the same, not typical. Actinomycosis has this special place for the living. It's the distal part of the third molar, retromolar area. It's the binormal microflora of the oral cavity. Imagine, patient suffering from tuberculosis. Immunity low. Patient takes 6 or 8 months the antibacterial therapy specific. What about the immunity? 0. What can happen with normal microflora? Grow. And if the patient has problems and needs to sanitation of the oral cavity, it means that the patient has carious cavity, pulpitis, periodontitis, roots, plaque. Yes? Perfect. Who kills the microbes in oral cavity?
Saliva.
Not saliva.
Oral hygiene.
Who kills? We have the name of these killers. Macrophages. They all penetrated, they all inside. And we have the same connection in the oral cavity with macrophages. What else? Who can help us? Who else who can help us to fight with microbes?
White blood cells.
C-reactive
C-reactive
proteins. And in oral cavity, who lives?
Myrcene.
This is the ferment who stopped the producing the microorganism because they destroyed the matrix for producing the microbes.
Why this?
Perfect. If the patient has low immunity, macrophages cannot fight for 100% like it was, like it normal. This small concentration and the normal microflora applied and fight with other microflora and change the position of the life. Which vessels helps us to finally destroy the microbes? Which side?
Lymphocytes.
Monocells.
Lymph nodes. Lymph vessels and lymph nodes. Absolutely true. These macrophages, activity for 60%, takes the actinomycet and starts to destroy it. But macrophages not enough power for destroy it. Of course, by the natural process, this combination macrophage antibody antibodies
Antigen.
Yes, antigen, antitela. Antigen antibodies is the complex, and these macrophages going to the lymph nodes for finally destroyed. But no power for final destroying. What happened inside the
Enlargement of the
lymph tissues stimuli other not macrophages, other cells to destroy, to help to destroy. But generally, no normal immunity, and they can produce about from 100%, for example, for 50. They 50% kills slightly, but actinomycetes live. What happens? They destroy the macrophages, and macrophages will be like the proteins for replication, the anti-mycetes. Understand what I mean? And start the inflammation specific inside the lymph nodes. Understand the mechanism? Imagine, patient has low immunity. From anamnesis, patient has a treatment about the tuberculosis. What happened in lymph nodes? This is enlarged
Enlargement of lymph nodes.
with fistula formation, no mobility normal of the lymph nodes. The contours about 1 to 3 centimeter in diameter, like this one. Pain under the palpation, moderately pain, and very interesting characteristic, almost like the cartilaginous consistency. What normally the consistency of the lymph nodes? Soft and tender. If it's the cartilage, does it mean that the lymph nodes lost the elasticity and the tissues inside lymph nodes change? It's the first general information from this. And the second, scanty purulent discharge, in which individual cord inclusions can be treated, can be trusted. It doesn't mean that small pieces take away from these lymph nodes with purulent discharge. If you remember the syphilis, actinomycosis, and tuberculosis, it's absolutely not clinical symptom for syphilis. Understand why? Not typically for the syphilis. We need to differential diagnosis between specific, non-specific. It's not non-specific because we have different clinical symptoms from the lymph nodes. Then we need to separate between tuberculosis and actinomycosis. Because you remember that actinomycosis, we have 10 forms, yes? Skin, under the skin, skin and the muscles, deeper in the muscles, the actinomycosis of the sinus, the actinomycosis of TMG, the actinomycosis of the salivary glands, the actinomycosis of lymph nodes, blah, 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 blah. What do you think? What is it, the right disease? Tuberculosis or actinomycosis? It doesn't mean that the mycobacteria of tuberculosis need to come back to the lymph nodes. And the first investigation was in the lymph nodes. From anamnesis, no problem. Patient has had from anamnesis tuberculosis, but this is the actinomycosis of lymph nodes. Understand why, not tuberculosis.
He has a problem in his lung, I think.
The patient received treatment for chronic sluggish pneumonia. Bacteria, yeah. Make a plan for an additional examination. You analyze the clinical symptom. You analyze the area of enlarged lymph nodes. 50% for tuberculosis, 50% for actinomycosis. Make a plan of additional. Which type of additional examination we need to prescribe? Cytological and blood tests. Then, make a differential diagnosis between specific, non-specific, specific between tuberculosis, actinomycosis. Syphilis, no, we understand why, yes? It's not the syphilis. Make a definitive diagnosis. How to answer? If after additional examination, we take the information about cells of Pirogov-Langhans, what will be the diseases? Tuberculosis. If you can find the giant cells of Pirogov-Langhans, it's a tuberculosis. If you found the actinomycetes, the drugs of actinomycetes, it will be actinomycosis. That's how to answer on the last question. Because from From this, we don't have information about the additional examination. We can only imagine, understand why? Make a differential diagnosis, what will be between which diseases, and if we take the information from the cytology with this, it will be this, with this, it will be this. If you answer only, if we take the information from histology, we think that it will be tuberculosis. You need to analyze why it will be tuberculosis. To understand it, we need to take that if you answer like with giant cells of Pirogov Langhans, or it's your opinion about right therapy, about the right diseases. Understand it? Answer like this, not answer. We wait what was the result and take the final diagnosis. No. If your answer was like this, will be additional question, many questions. Patient 60 years old complains of pain in the nose. Anamnesis: 3 days ago I independently tried to squeeze off the formation of the skin back to the nose of the left. After extrusion, there was a swelling on the nose, the suborbital area on the right and left. 1 day ago, there was a throbbing pain in the area of the back of the nose on the left. She was treated with home remedies, used Analgin, aspirin, and applied dry head to the side wall of the nose on the area of the left. Perfect. First, big letters. What was the mistake? Patient at home.
The squeezing of the
Worm and aspirin. Why we don't prescribe aspirin? What happened with the quantity and quality of the blood? They will be more liquid. Okay, what happened if we can use in the infiltrate in the inflammatory worm? We stimulate immediately, change this the part of the alteration to exudation, and exudation immediately to the purulent. We immediately change the phase of inflammation if we can use the worm. What did worm with structures? Which structures answered for the inflammation? Blood vessels. What happened with the worm with blood vessels? Direction, yes. What happened with the blood wall? The blood wall has small spaces for changes the pressure. If you can use worm, they decrease and all liquids go immediately from the blood vessels around in the soft surrounding tissues. Edema from this, like this. What do you think? Temperature now, 75 and 9 degrees. Configuration of the face has been changed due to the swelling of the bridge of the nose suborbital area of the right and left. The skin in the area of lateral surface of the nose is sharply hyperemic. On palpation, the inflammatory infiltrate is painful in the center of this fistula with purulent discharge. Make a preliminary diagnosis. How to write answer on furuncle of which area? Of the leg? Furuncle of the nose. Why it's not the carbuncle?
Because the carbuncle many in one. More than
More
one.
than one.
Make a differential diagnosis.
Erysipelas.
Erysipelas. Any specific diseases. Remember, actinomycosis and tuberculosis and
Sepsis.
Perfect. What complication are possible to develop in this disease? Thrombosis of cavernous sinus, yes, that's right. And the thrombophlebitis, yes, and finally, what happened if it's going deeper? Meningitis. It's the huge systemic inflammatory disease, complication and diseases. Make a treatment plan for the patient and specify the place of treatment. Which type of treatment will be conservative, surgical or surgical? Surgical treatment. Why we don't use conservative and surgical? You have in the center the fistula with purulent exudation. Maybe you can use only the conservative therapy.
Maybe yes, we can use
remove the pause.
We need to incision.
We need to do incision. We need to use surgical therapy under the
Local inflammatory.
local and systemic general anti-inflammatory and local anti-inflammatory therapy. Why this specify the place of treatment? How we need to open this space. Unfortunately, we cannot cross deep here because will be aesthetically scar formation and you can lost the part of the cartilage. Will be after deformation like after syphilis. You remember the woman at the old picture without nose, like this one. How to open this? Here, inflammation.
We go with the fold of the nose.
We need to cut here. Here, understand it? Because we can cut only the skin, then under go to this focus of inflammation. And when it's growing, the scar will be in the deeper fold, deepest area, and it's not clear to see by the different person. In which department? Maxillofacial surgery department. How many days we need to prescribe general anti-inflammatory therapy?
7-10 days.
7 to 14. We appraise the complications.
Recurrent.
And here, if the temperature of the patient 37 and 9, and for prophylaxis of complications, we need to give the patient desintoxication therapy. Antibacterial, antihistaminical, desintoxication, painkillers, and local anti-inflammatory therapy. Anti-inflammatory therapy consists of antiseptic irrigation and applied of the ointment, for example, or gel, Metrogyl gel, or levomicol or Gioxazone. For how many days we applied local anti-inflammatory ointment? 3 to 5. On which it depends. It depends when finished purulent exudation. If you can never see purulent exudation and antiseptic irrigation, this is the clear. It doesn't mean that its space is clean now, and then we can apply the medicine who stimulates the regeneration. For example, like Acepta or like a Sulcosiril. Acepta or
Keratoplasty.
yes, Sulcosiril. See you on it there.
Thank you.